Good morning, everybody. Sorry we're running a couple of minutes late this morning. Thank you for joining another Monty Hart session. We have today a good friend and um, a former mentee. And it's always nice when a mentee is now a mentor, who's going to be talking to us about calcified coronary lesions and some of the special balloons we can use. I think this is an area, calcified lesions is really an area that's becoming more and more important in the cath lab because our patients are becoming older, more complex, more challenging. I also wanted to use this morning to welcome um, a lot of young colleagues who are yet interviewing today at Montefiore to join our cardiology fellowship program. I hope you get a taste today of the expertise that's available at Monty. And it encourages you to want to join us and learn from us. I think we're very lucky to have a very internationally renowned faculty and a lot of teaching for fellows and senior staff alike. So without further ado, Antonio, it's all in your hands. Thank you so much for taking time out of your day to spend with us. And I think we're going to make this a little interactive, right?
Yeah, for sure. Otherwise, it's boring. Let's say, let's say that the pleasure of this lesson is to be interactive and to learn also from each other. So the topic of the discussion, as you introduced today, is the treatment of a calcified coronary lesion. But today we will discuss about some special balloons that usually are utilized, but maybe not a lot of people know very well about them. And we will see that they are completely different, especially in terms of performance and also possibilities that we have using these tools. And I want just to start, I'm Italian, we are a little bit artistic, and you know that the sculptor has multiple devices to do its work. And sometimes, the final work is the result of multiple devices and techniques that you can utilize. You see that these are two masterpieces, one from Michelangelo and another one by Giuseppe Sammartino, and you see that the level of details that we have in this case is completely different, maybe because they had utilized different tools. And at the same time, when we are, interventional cardiologists, we are dealing with rocks, calcium, and we have multiple devices and techniques that we can utilize to obtain the final result, which is a PCI. But you know that the final result of a PCI can be different according to the different tools that we use. And with the passing of time, there's a great availability of the different type of tools that, we are learning how to use them. So we have a lithotripsy that I know that in United States is nicely and extensively utilized. We have the root ablation, we have orbital atherectomy, but we have also these new balloons, old balloons, sorry, the cutting balloon, the scoring balloon, and the super high pressure balloons, which are available. And we have to learn how to use them. Why? Just a brief introduction. I know that it is a bit boring, but I just want to remind all the guys that the problem of coronary calcification is not so, irrelevant. In presence of severe calcified lesion, the rate of failure of the lesion that we usually treat is dramatically higher compared to those lesions that have no calcification or mild calcification. You see from this important registry what is the impact of the severe calcification with implantation of second generation DS at 1 year, so a very short follow-up time. You see that the rate of the TLR for severe calcification is around 7.5%, which is quite double compared to other non-calcified lesion. And you see that there is an impact also in terms of myocardial infarction, target vessel vascularization, but severe calcification have also an impact in terms of MACE. So it's something that we have to deal with and we have to take care of. Usually, severe calcification can be detected at the angiography, but the better tools to better identify what is the thickness or what is the behavior of calcification is using intravascular imaging, especially IVUS or CT, can be fundamental in the definition of mild to moderate calcification, in evaluating the depth of calcium, in evaluating also the length of the calcium arch, and the thickness, especially with your CT, can be nicely evaluated. But sometimes you see that, especially in very challenging and dramatic cases, you see that we don't need essentially the imaging, intravascular imaging, to have, a meticulous assessment of our strategy. Like in this case, you see that there is a big chunk of calcium at the level of distal bifurcation of the left main. Maybe this calcium can be classified as a nodular calcium with some other calcium in the surface. So I think that in this case, a technique of ablation should be considered upfront, even because I think that it's impossible to cross this lesion with simple balloons. But sometimes remember that the angiography can also overestimate. So we can see a lot of amount of calcium, which can be adventitial, and I think that we sometimes we do not need like to start up front with a strategy, but if possible, let's have a look deeply. Let's use IVUS, let's use intravascular imaging to have a better evaluation of the IVUS, because sometimes people start using rotational atherectomy, but sometimes the lesion can also be approached using simple balloons with the possibility to have a good results. We have a lot of scores based from OCT score, IVUS studies. I think that in some cases, these scores are a little bit boring, and they are focused on some aspects which are useful for the clinical practice and at the beginning, but with the passing of time and also with the experience, I think that these can be useful, but it's something that does not give us a definite answer to what is the best tool to treat some lesions, even because I think that this intravascular imaging has one big limitation. So we are not able to understand what is the quality of the calcium, like we do, for example, for the CT scan of TAVR patients. Using the Hansfield unit, for example, we can understand what is the density of calcium, what is the future of calcium, but this is not read by the intravascular imaging. And so sometimes, even if we apply some scores, we can have some surprises, let's say, something like that. So, also some algorithm. I think this is something that is redundant, but let's just say that we have to look at the balloon crossability, and according to most, of the available algorithm in calcium modification, a big important role is played by the special balloons or the non-compliant balloons that can be utilized to test the lesion and to try to understand if the lesion can be prepared. So special balloons are cutting balloon, scoring balloon, and a super high pressure OPM balloon. So let's give a look in detail to these tools that we have in our cath lab. So essentially, the cutting balloon is considered by Boston Scientific as a non-compliant balloon, but we will see that is not completely true, because it's mounted on a non-compliant balloon, but the behavior is of a semi-compliant balloon, and he has 3 blades which are mounted on the superficial surface. You see that the blades are not so high, and what changed compared to the previous generation of cutting balloon, the flex tom, is not the blade itself, but is all the adhesive bond and the cast pad which attach the blade on the balloon. You see that compared to the thickness of an LAD of the wall of a normal gentleman, the cutting properties are not so dramatic. So the possibility by the cutter to come inside of the vessel wall is not so dramatic. You see that, as I mentioned before, the cutting balloon is considered by the company a non-compliant balloon, but I think that this compliant chart is fundamental, because When we inflate the cutting balloon, which is nominal pressure of inflation is 60 atmosphere, I think that when we go up to 12 atmosphere or even higher at 18, 20 atmosphere, the diameter of the balloon increases dramatically. So you see that we pass from the 3.0 diameter for a 3 balloon at 5 atmosphere of inflation up to 3.3, 3.5 also for inflation up to 18, 20 atmosphere. Let's say that our philosophy is to inflate the cutting balloon at high pressure, and I will show you how to do it. Compared to a non-compliant balloon, and this is something that I learned directly from Azim, but is reported in literature, you see that Wolverine cutting balloon is fundamentally important because compared to a non-compliant balloon, which is inflated at 20 atmosphere, you see that the tensile forces which are applied to the vessel wall with a Wolverine inflated at lower atmosphere, so at 12 atmosphere, is higher. And we have a lot of stress which is applied in the region in which the blade comes inside of the vessel wall, but also between the two blades, you see that I have the possibility to apply more forces compared to the standard non-compliant balloon. So it means that in calcified lesion, if we go up to 12, 18, 20 atmosphere, compared to a non-compliant balloon, we are obtaining a higher stress on the vessel wall. And so thanks to this factor, we have the opportunity to obtain a better lesion preparation compared to a non-compliant balloon. So cutting balloon is not only a non-compliant balloon with blames, but is something which is more advanced from a technical point of view. But this should be utilized in a very careful way because of the problem of the semi-compliance. So the key element for the treatment of calcified lesion with the cutting balloon is always to downsize of 0.5 millimeter compared to the media to media diameter and to go high pressure to obtain the better results. And if we combine rotablation plus cutting, for sure we will obtain more cuts, more fractures in the calcium compared to the use of a non-compliant balloon. So let's start with some practical cases that we have done in our cath lab. And so you see this angio of a patient that we have treated, I think, 4 or 5 months ago. You see that there is a diffusely calcified RCA, I think with a moderate stenosis, a very long disease, but I think that it can be left to medical treatment. While you see that there is an intermediate lesion on the left main, plus I think a severe clear-cut lesion at the level of the proximal LAD. So I think that looking at the angio, my impression is that this, let's say, LAD is moderately calcified. And I think that in this case, the best thing to do is to go for an IVUS. So Azim, my suggestion now, I have the IVUS run. Would you choose one of the guys to comment on it, or you want that I proceed?
Let's get someone to comment. So we'll choose Andrea Mignati to maybe comment. Are you going to show the IVUS first or
yeah.
after?
Okay, let's see. This is the IVUS run, Azim, as you can see. I think the pullback is done just from the mid part of the LAD up to the proximal part. And of course, we did also the pullback to understand about the severity of the left main, because you see that in this projection, I think it's an epicranial projection. The left main looks like borderline. If you want that, Ariane, again, the IVUS.
Yeah, let's run the IVUS one more time to give Andrea a little chance. And if any of the other fellows are on, just raise your hand and I'll promote you so you can make comments too. So I see Saul as well, but who wants to comment? Saul, you want to comment, or Andrea?
Hi, good morning. I am seeing here very tight lesion, concentric calcium throughout is a 360. In this case, what I would probably do is I would just by habit I would use a rotablator. This is by habit. If I were, I don't think it lithotripsy would be. I would have to struggle to get lithotripsy through it. So that would be my first choice in this case. Go with rotablator.
Yeah, I think that's a good thought. The only thing that worries me a little bit, and I don't know, I'd measure, if you see the bottom right picture that Antonio is showing, where there's the 360 degrees of calcium, I'm not sure what the diameter there is, but I suspect that it's almost 2 millimeters.
Yeah.
And if it is, then your atherectomy, you're gonna have to go with a really large burr, right, to be able to impact it. So, I might try and see if I can get lithotripsy down, even if I have to use a supportive wire or to use a cutting balloon, a Wolverine, which I want to stop calling it cutting balloons because it doesn't actually cut. But that's maybe what I would consider in this case. Anybody else?
Good morning,
I
Dr.
see Dr. Colombo there as well. Now we really bring out the big guns. Okay.
Prof, venga. We promote Antonio Colombo as correlator.
Hey, Antonio, good to see you.
Prof, look at this case. Yeah. Just one moment, I run again. So this is an LAD, and this is the IBUS run before. You see that there is some circumference and calcium.
Is not small.
Yeah, there is another tight lesion just before, like around this area, which we do not observe a lot of calcium. There is some fibrosis, there is some lipidic plaque, and this is the end of the pullback. You think that we should go up front for rotablation, or you think that?
No, to me, it's too big for rotablation, unless you are still using a 2.5 burr. That is difficult to find, especially to find a 9 French guiding cat.
we did one, me and you, remember?
With Dr. Azim, with Dr. Latif, we did. It was a kind of stormy procedure.
I think it was the only 9 French guide catheter in the whole of Europe.
Honestly, here you can try with a high pressure balloon. If you can afford, it's very elegant to do lithotripsy. But I think lithotripsy is a home run. With a calcium 360 is very nice. But if you have economical concern, you can try high pressure balloon.
Yeah. And the other thing, I think that the longitudinal extension of calcium is not that dramatic.
It's very focal.
It's very focal. So every time you have like a focal calcium, I think that you can at least have an attempt with a normal balloon, a non-compliant balloon. So let's see, the diameter was around 3.5. The proximal LAD was around 4
Non sta cambiando lì indietro. Just keep your toes on, Antonio.
So you see the balloon works nicely. You see from the angio and also from
which size balloon did you take?
3.5, solid 3.5. But so let's see also now the IBUS run what we obtained. You see that pulling back, we are still some island of calcium around 3 o'clock. Coming back.
Is there any case where you would start with a cutting balloon from the beginning, or we almost always try a standard high pressure balloon?
I tried the standard high pressure balloon, and then I almost all. Also in terms of crossability, I think that is better. So
I think crossability is better, but I would not be against trying a cutting balloon as my first balloon yet.
Okay.
A Wolverine, because I think I would have undersized it though. You use 3.5. If I've gone with a Wolverine, I would have gone with 3.0. okay, so that I can get to high pressure, because you showed very nicely the compliance chart, right? And you showed how the 3.0 or the 3.25 by like 12 is over 3.6. So the 3.0 by 12 atmospheres is going to be about 3.4 already, 3.4 millimeters in diameter. And so if I want to go to 20 atmospheres with the cutting, with the Wolverine from the stop say cutting, I would have then maybe chosen a 3.0.
Okay. Azim, looking at this IVUS and the angio that we did after, are you happy with this result?
The angio looks good. I'm just trying to look at the IVUS where the calcium is.
Yeah, the IVUS is coming back. You see that there are some small cracks.
Yeah,
there's
I see fractures. There you go.
Yeah.
There's a nice fracture.
Yeah. The problem, I think that in some areas, there's still like some solid calcium that is not well prepared. At the angio, I think the lumen gain compared to the baseline is nice. Still, maybe something can be done, like to obtain a super perfect result. And so in these cases, I think that we are dealing with some moderate to severe calcification, and we have designed this study just to understand if a Wolverine balloon can give us, a plus compared to non-compliant balloon in this trial that has been published on CCI, the COPS trial. Essentially, we randomized 100 patients to cutting balloon and non-compliant balloon.
I'm gonna go. I have to go to the clinic. Okay.
Ciao, Antonio.
Ciao, ciao.
So you see, we are dealing in this trial with moderate to severe calcification, like the case that I've presented. And just to go briefly, you see that in the trial, we obtained a similar MSA, but if we look at the MSA at the level of calcium site, in the cutting balloon, we obtained a greater area compared to non-compliant balloon. And also we obtained a better eccentricity index at the calcium site. And this was true, especially for those patients treated who had an arc of calcium more than 270 degrees. So this is a COPS trial patient, let's say that, and after non-compliant balloon, I went up with the cutting balloon at 3.0. So I want to remark that before we pre-dilated using the 3.5, but in this case, to go higher pressure, we downsized the cutting balloon and we went up with the 3.0. And if we look at the IVUS run, Azim, compared to the previous one, I don't know if you remember all the run, but essentially, I go a little bit quicker, but you see that the areas with the organized, calcium are mostly disappeared. I think that we obtained a more nicely prepared lesion with the more evident cracks in pullback. And also at the end, you see the appearance that there's a tiny dissection at the level of the diagonal, but was a very nice and benign dissection. So here the concept is not like to do the simple angioplasty, but to do and to try to understand how to achieve a perfect angioplasty with a perfect result, because we want to improve, our clinical practice and our practice in the laboratory. Then we placed this dynamics stent, because this patient was also included in the trial for this biodynamic stent implantation. You see the final IVUS run, but I think that we can go straight to the OCT finding. You see that at the OCT, the result is essentially perfect. We had a very circular, a very nicely expanded stent with a very nice final result. And I think that we obtained this result without using lithotripsy. I know that lithotripsy, is maybe safer and maybe better. But you see that using like normal tools and normal balloons that we have in our cath lab, we can achieve a very nice result. But always remember to go high pressure, but to downsize compared to the media to media diameter.
I really like the stent expansion there on the OCT. And I think, if you just put the stent in after the non-compliant balloon, I think your MSA would have been acceptable. Yeah. But I don't think your stent expansion would be as circular as it was in that final picture, right? Yeah. And so, we used to have a lot of discussion And I think it's important for the fellows to really, if you have a stent that looks like this, very circular versus a stent that's more oval, doesn't matter if the cross-sectional area is okay. Now, there is some data saying it does matter. And the whole concept is if your stent is like very oval, right, like that, instead of this, if it's like that, you get what's called non-uniform drug distribution. So you will have some areas where the stent struts are very close, because remember, all the drug is on the stent struts, right? So you have some areas where the stent struts are very close, and you get a lot of you get good drug distribution there. And then other areas where the stent struts are further away. And so the drug distribution will not be the same. And you may have gaps in drug distribution. So there's been like a lot of data in the past about uniform versus non-uniform drug distribution. And maybe non-uniform drug distribution is one of the reasons we see higher risks of restenosis and more intimal hyperplasia in patients with calcified lesions.
Yeah, and I think, Azim, especially when we are dealing with the LAD, I think LAD is our Lima, surgical Lima. So we have to do the best that we can for the patient. And even if we are dealing like with a very short lesion, I think that we have to achieve the best that we can, just to be competitive with the surgery. So let's go to the next case. This is a 72 years old male with symptomatic for angina and dyspnea. He had a stress perfusion imaging positive in the anterior wall. And you see that is quite similar to the previous case according to lesion, location. We have a diagonal branch which comes from the lesion, and I think that looking simply at the angio, this can be considered a moderate to severe calcification of the LAD, proximal LAD, with some other diffuse disease all the way down.
So Antonio, maybe let's move. You have imaging. Great. Go ahead.
Yeah, I have imaging,
and we'll ask Saul to comment.
Yeah, unfortunately, I don't have the IBUS run, but I have some still frames you see here. Who wants to comment about these maybe frames that we see?
Saul?
Hi, good morning. Yes, so looking at the IBUS, you can see that you have severe calcification. You almost have, I would say, 90% of the vessel wall is covered by calcium, and it correlates with what you see on angiography. You will need to do some calcium modification before putting any stents in this lesion.
Okay. You see some fibrosis. You can say that there is some fibrosis. You can say something about thickness of calcium in this case.
So I don't see any calcium nodules. I see some fibrotic plaque, and basically that's it.
I mean, it's very
plaque
concentric,
and
right,
calcification of the wall.
And
it's kind of difficult to tell the thickness of calcium with IBUS, right? Because
exactly.
the sound doesn't go through the calcification as opposed to OCT.
Yeah.
Yeah, that's a good comment that Saul makes. I think it's very difficult to say thickness of calcium. I think IBUS is very good at detecting calcium, showing the length, whether it's superficial versus deep, but thickness is challenging.
Yeah. Let's say that in most of the cases, it looks like to be a superficial calcification. We see some black behind the calcium. We see some reverberation. It seems to be a mixed type of calcium, but I agree with you that it's very challenging to define the depth of calcification. For sure, the extension of calcium is around, I would say, 50 millimeter, maybe. So it's a quite long calcified lesion. What is your suggestion for the lesion preparation in this case?
So I would get started with non-compliant balloon and see how it expands. It's probably not going to be sufficient, but it's going to give me an idea of the size of the vessel. Well, we already have a size of the vessel with the IBUS, but then you can try passing a scoring balloon or a cutting balloon and see if that goes through. If you're having trouble delivering your equipment, even with a guide liner or with a stiff wire, then I think the next option would be rotablade, because of the extent of the calcium that you have going from the proximal LAD all the way down to the lesion and probably past the lesion as well. So you could get started with a Wolverine, for example. If you have trouble delivering it, or if you have trouble expanding it, then you can upgrade to rotablation.
Okay, excellent. Would you mind about the diagonal, which is another question that we can ask just for, you know, the strategy of PCI?
Yeah, what I've seen, we typically do, we wire it, and that way we demarcate the location of the vessel, and then we work on modifying the lesion on the main branch, and then we observe how the side branch responds to the treatment that we're doing. If we need to balloon it, if we need to stent it as well, we'll decide afterwards. But it also looks pretty tight, so I don't know how well it's gonna hold up after all the calcium modification in the LED.
Okay, so just general suggestion. It's what I did. I decided to protect the diagonal. The other thing that I prefer to do, I always start with a 6 French guiding catheter. In these cases, rarely I use the 7 French, but if the PCI can be very tricky, I prefer to upgrade to 7 French. If I go from the left radial, I prefer a type 4, so let's say a 4 curve. If I go from the right, I prefer 3.5, but usually I prefer a bigger guiding catheter to have more support in these cases. So just practical things. So I decided to protect the diagonal, but also to pre-dilate. It was very difficult to come across the diagonal, so I utilized a semi-compliant balloon. But my suggestion in this type of PCI is never to use semi-compliant balloon because of the dog boning effect and asymmetrical distribution of pressure that can gives you a not remote risk of perforation, rupture, etc.
But I think also when you do it for side branches and you use semi-compliant balloons, you tend to get more dissection at the side branch, right?
Yeah.
So I think you're right. I think as a practice, using a non-compliant balloon, especially for side branches or when you do kissing inflation, makes a lot more sense because you don't get overexpansion.
Yeah, that the thing that maybe I've not done is to pre-dilate in this case, I think, because when you pre-dilate the side branch, the risk is, especially with a semi-compliant balloon, is to have dissection. And if I have to rewire, I have to go across like dissected the side vessel, the side branches, which is not like a good thing to do. But let's say in this case, we pre-dilated the diagonal. You see that we inflated a non-compliant balloon 3.0 at 24 atmospheres. Are you happy with the result? Just looking at this picture, it seems that the balloon is symmetrical, asymmetrical. You want to achieve more?
Yes, I can't see the balloon markers really well. Let me see if I can. So I'm not happy. I don't know what you think, Saul, but to me, just proximal to the diagonal, it looks like the balloon's not fully expanded.
Yeah.
So I would not be happy putting a stent. What do you think, Saul?
Yeah.
No, I agree. There's some dog boning, as we call it. The balloon is not fully expanded there, so that lesion still needs some modification, I would say.
Yeah. I think I totally agree with you. And so let's go to the next slide. This is a small puff. Every time I go very high pressure with the balloons after pre-dilation, I always do a small puff to understand what's going on and also to see what is the behavior of the vessel. You see that there is also this small puff. There's a grit recoil around the diagonal. So it means that the lesion is not well prepared. And also the IVUS, you see that the residual area that we achieved, especially with this in this picture, is not excellent. And in some areas, you see that there is some cracks of calcium, but in some areas, the calcium is still not well prepared. So we pre-dilated with the 3.0. The vessel is around 3.5. I think it's in this case is safe and reasonable to go with a cutting balloon. So that's why we did. And you see that the expansion of the fluoroscopy of the cutting balloon is completely different from the non-compliant balloon. So we went at the same atmospheres. We utilized the same size of the balloon, but the results was completely different. You see that now the balloon inflation is symmetrical. We have not the boning effect, and I'm happier also with the IBUS finding. You see that here the calcium is completely destroyed. So I think that now it's time, and just now you can proceed with the implantation of the stent, and you see the final result, which is, I think, pretty nice and pretty good. And this is.
Except I'm gonna go back. I want to challenge you a little bit. And we're lucky we have. I see someone I respect and I look up to in one of the videos here, Dr. Presbitero. For those of you who don't know, Patrizia Presbitero is an internationally renowned interventional cardiologist who I respect and love, and I've learned very much from her. Patrizia, I'm going to argue and say that maybe Antonio was a little bit lazy that day, because the diagonal is a big diagonal branch, and he left it alone with a result that doesn't look so good.
Because I am very old, I would have started with rotablation, I have to say. In any case.
That's not old. I think that rotablation is still very, very good today.
And then the diagonal, I think it doesn't look very nice. So I don't know if you did something more in this diagonal. It's a long but small vessel, so probably insisting with a balloon probably maybe would have looked better. But
I might have gone back at the end and kissed and maybe put a drug-coated balloon or something at the ostium of the diagonal, because it's a long diagonal, so it supplies at least 10% of the myocardium. I mean, it's longer than 70 millimeters, right? So it may not be large in diameter, but it's very long with multiple branches.
Yeah, so, a kissing balloon would be appropriate, I think. Yeah.
So the problem here, I have to be honest, because honesty always is
fundamental. Always pay, yes.
So I tried, as I mentioned, I pre-dilated the side branch and I dissected. You see that at the ostium there's some minus. So I tried to rewire. It was not a good attempt. There was also a bit of worsening of the blood flow across the diagonal. So I decided not to insist more and not to stop, because I think that in this case you can propagate the dissection and you can even have like a worse result. But I agree with you that the thing to do in this case is a kissing balloon, maybe with a DCB is a good idea.
Yeah. Good, as long as you tried. Now we're happy.
Very wise, Antonio.
So this is the final result. We did a DCB down because of a bit of mismatch between the stent and the native vessel. So we pre-dilated and we released also a 3.0 by 20 millimeter drug-coated balloon with the paclitaxel. You see also at the IBUS the result. So the stent looks reasonably good in terms of expansion, and we were finally happy. The post-dilation was done with a 4.0, especially for the POT, the proximal optimization, and this was the case. Okay, we have this other case, which is a short case. I will say why. So 66 years old, hypertensive, effort angina, positive treadmill test. So Azim or the fellow or Dottoressa Presbitero, you see that there is a critical stenosis around the diagonal. I think we are moving in the mid portion of the LAD. After the diagonal, there are a lot of calcification, you see, especially in this part. I think there is another stenosis just before the diagonal and there is a discrepancy in terms of diameter between the portion of the LAD before the diagonal and after the diagonal. It's a big diagonal branch. So what is your approach in this case, Azim? Just looking at the angio.
I'll tell you what I think, because I think I'm also old, like Dr. Presbitero.
Not as old.
Oh, come on, you look great. So I think, different to the other cases you showed us, Antonio, the calcified area is longer here. Okay, it's not as focal. So I'd be, you're thinking about rota, maybe a 1.5 or even 1.75 burr, maybe even 1.75. It's a really big LAD, but I'd really be thinking about using rotablation here in this case, just because it's longer, and I think I'm going to make my life easier. Patricia, what would you do?
Yeah, I think so. The good thing is that the bifurcation with the diagonal seems to be quite safe. But if you have in any case to put a stent from the first stenosis and the second, and maybe with the rotablation first, you end up with a good results, maybe in the good expansion. So I would try rotablation first.
And I would, and I agree. I would try to be provisional for that large diagonal, because I don't see a lot of disease. The disease is before and after.
Yeah.
Okay. So very easy case because nothing crossed, was an uncrossable lesion, and so we had to rotablate up front. We utilized the 1.75 burr, and the lesion, I think that the burr went nicely down. We did some runs, but finally was okay. So these are the IGOS finding after non-compliant balloon that we did after rotablation, because after rotablation, I think that is always mandatory to post-dilate using non-compliant balloon. And you see the behavior of the non-compliant balloon. So seems to have like some dog boning before the diagonal, seems to be a little bit underexpanded, especially after the diagonal. So let's say that this is a quite challenging situation. I think that after rotablator is always easier and safer to use lithotripsy when you have such cases. Rota cutting is described as technique to do cutting after rotablation, but I think that is the case in which you have to be very careful. So these are the...
let's just talk about that a little, because that comes up a lot, what you just said, right? Is you've done rota, and I agree with you. I think after rota, you always have to go with a non-compliant balloon, because rota may not cause fractures. It may, shave in the calcium, and you may see the effect of it without any fractures. So you have to go with a non-compliant balloon. Say that, like in this case, the non-compliant balloon doesn't expand. What's your next step? Is it, there's a lot of discussion about cutting versus lithotripsy. Lithotripsy, you have to remember, in the United States, it's very expensive. Right? It's like $4,500 a balloon. Okay, it's double the price of rota. Okay, and a cutting balloon is maybe less than $1,000. So it's becomes a very expensive procedure. Is there any data that because you've looked at the data a lot, Antonio, to show that if you do cutting balloon after rota, there are more perforations versus if you did any other type of balloon?
So there's this registry of rota cutting in which they compare rotablator versus plus cutting versus non-compliant balloon. And I have to tell you that the efficacy is high because in terms of MSA is higher with the cutting balloon, but in terms of perforation, there's a big difference between these two techniques. I mean,
there is a difference?
Yeah, there's a difference.
Numerically or statistically?
Numerically, I don't remember statistically, I tell you the truth, but there was a substantial difference. And I think that you have always to take care when and to be very careful and very conservative when you do cutting after rotablator.
But even in your study in COPS, you had a numerically higher perforation rate with cutting balloon versus non-compliant. So
this was not significant from the statistical point of view, but in our study, let's say that we treated 42 patients and we have 2 Ellis type 1 perforation. Is an Ellis type 1, it's one was managed with implantation of a DS, the other one with a covered stent, but it's always perforation. And I think that's something you want to skip and to avoid in these cases. These are elective cases, basically. you have to be very careful, because if you have perforation, especially after rota cutting, you can, have troubles. Let's say that.
Yeah. I don't know, Patrizia, what do you think? I mean, I have a colleague here who does a lot of cutting after rota, and his perforation rate is very low. So I've been trying to do. I mean, Patrizia, you've been doing this, longer than a lot of us. I mean, do you have concerns about using cutting after rota?
No, I don't have experience of using cutting after the rota.
Okay.
My preference would be, did you try the high pressure balloon after
OPN?
high pressure balloon after having tried with non-compliant balloon? Or shock waves. I don't know if there is data on shock waves after rota ablation in terms of perforation or complication. Antonio, maybe no.
Yeah, we published, our group published and contributed with Stefanini to the rota shock paper that has been published on the American Journal of Cardiology. I think that they have just one perforation in all the registry, so it seems to be a very safe approach.
Yeah, I mean, we published on it as well, from our center, atherectomy plus shockwave versus shockwave alone. And in the atherectomy plus shockwave group, there were higher rates of complications and just a higher mortality as well, which was interesting. And I don't think the mortality was specifically related to the procedure, but just it almost like, the fact that the patient needed both modalities, it meant they had so much calcium, and it identified them as a high risk patient. They tended to have more end-stage renal disease and hemodialysis, lower ejection fractions. And so they just had, the outcomes were a little bit more guarded compared to the ones who just did well with shockwave. So I think there's something to be said about those patients.
Yeah, I agree. So in this case, you see, so what is the behavior of the 30 millimeter non-compliant balloon? I think these are the measures. So after the diagonal, we have a media to media, mean media to media diameter of 2.9, and before the diagonal, the vessel, of course, becomes larger. So here, no cutting balloon. I decided to go with a 30 cutting balloon, and you see that if we go high pressure, the 3.0 can become, like I said before, almost 3.5, let's say, something like that. So this is the balloon expansion. I think that is good. I think it's promising. I think it's more symmetrical compared to the non-compliant balloon. What do you think, Azim?
Yeah, I think it's better, but I want to see it more proximal, because I think when you showed me the non-compliant balloon, it looked worse, more proximal.
Yeah. I tell you that there is not a more proximal, because this was
God. Oh God.
This is the big surprise that we had. So this is not a perforation. This is something that is more a perforation.
So let me ask you, what pressure did you go with the cutting balloon?
24.
So, I mean, go back one picture, and I'm gonna be critical for the fellow's sake. Go back again, all right? I mean, no, forward. So I'm looking at your diameter here, right? Your media to media after the diagonal is only 2.9.
Yeah.
All right. I would not have taken the cutting balloon to high pressure after the diagonal.
Yeah.
Right.
Yeah.
If I thought you're going to say you took the 3.0 and you went to, nominal after the diagonal, and then use the same cutting to high pressure proximal to the diagonal. Because when you go to the next page, next picture, next slide, you show us this. No, go back. Right. And like you said, it's 3.3 already at 12. And at 24, it's 3.5.
Yeah, that's
so
the point.
I don't think we can blame the cutting balloon, but we have to blame
the
operator.
No, that's we have to blame the operator.
Antonio did it.
No, but you learn from the mistakes. I think that you have always to be critical with what you did. I think that in this case, if you want to use cutting balloon, you have to take 2.5 high pressure after the diagonal, and then you go with the 3.0 before the diagonal. I think that's the thing to do if you want to go high pressure. Otherwise, you can just, you know, stop at low pressure and nothing happens. But I tell you also, Azim, that the image that you see in which you appreciate that the cutting balloon is nicely expanded is something that we achieved only going high pressure. I mean, we pre-dilated, we stayed at like 16 atmospheres because we had some concerns because we were treating an area with a smaller area, but the problem was that the cutting balloon was not nicely expanding. So I think this is one of the key messages that I want to give you during this presentation. If you have to use cutting balloon, especially after rotablation, the suggestion is always to downsize if you want to go high pressure.
There's a question from one of the colleagues, from Hussein, Dr. Chakra, I think. Hussein, go ahead. I see you raised your hand. Did you want to make a comment? Hussein, we can't hear you.
Can you hear me?
Yes, we can hear you now.
Yeah. I just want to tell you, I'm glad that you have that picture. I wanted to tell him before I didn't get the chance. Once you see the balloon like that, the taper down and the expansion in proximal, just get your covered stent before you deflate this balloon, because this is a sign of rupture there.
Yeah, but this is so I tell you what
this is just for, no, I understand, but I'm just telling you about the balloon. Look at the balloon. The moment saw the balloon inflated in this way, I tell you this is a sign of rupture there. Yeah. So just get it in the room before you deflate, and then you could do whatever you want just to be in the safe side.
Because this is a tapered balloon in this area and is bulging outside from the let's say vessel in this other part. So when I deflated the balloon, the patient had chest pain immediately. I inflated again the cutting balloon in the proximal part. I sealed and I utilized the ping pong technique. The image that you see here, it is the covered stent. And finally, like the result was that one. We implanted some other stents proximally. The covered stent is just after the diagonal. You see that the result is more than acceptable, but you see that you take the risk and you take a big chance to harm the patient if you don't do the things properly. But the key message, I think, is always to downsize. And if you have a tapering of the vessel all the way down, don't be lazy. And you can also use different measures of cutting balloon in order to be safer and to go safely high pressure. Okay, scoring balloon. Let's go to this other tool that we use in interventional cardiology. I'm not a big fan, I have to tell you the truth, of scoring balloon. Essentially, this is a more non-compliant balloon compared to the cutting balloon. And this is made from 3 spiral struts, which are made up of nitinol scoring element, and they wrap around a conventional balloon. So this wrapping around compared to the cutting balloon helps to maintain the compliance with inflation at a high pressure. And usually they're available in different type and different sizes. There's a big difference between different type of scoring balloon. I have to say that maybe the best one is the one from Philips, who has branded the new scoring balloon, which has a better trackability inside of calcified anatomy. And compared also to the cuts of the cutting balloon, you see that the diameter of the nitinol elements which are around the balloon are a little bit higher. So that's why the penetration of the scoring balloon in some circumstances can be better compared to the cutting balloon. This is another bench test. This is a comparison with a non-compliant balloon, and you see that the score flex compared to a non-compliant balloon can achieve a higher pressure compared to the non-compliant balloon in calcified anatomy. And if you remember also the slide that I show you about cutting balloon and the forces applied to the vessel wall, you see that differently from the cutting balloon, in which we had the appliance of forces also between in the balloon between the two blades, you see here that the higher force is applied just around the nitinol elements which are mounted around the scoring balloon. And the scoring balloon tends to maintain a higher, let's say, compliance compared to the cutting balloon itself. So we can go safer, higher pressure compared to the cutting balloon. So just my comments, I think that in mild to moderate calcification, scoring and cutting are mostly equivalent, but in severely calcified lesion, I think that cutting has a stronger performance. Despite some improvements in the design of the Wolverine compared to the Flexstom, I think that in some calcified lesion, the scoring has a better trackability, especially when you have to go to the circumflex. The scoring creates less malignant dissection, and let's say that a higher rate of dissections is observed with the cutting balloon compared to the scoring. And while the undersizing is mandatory for cutting balloon, I think that for scoring balloon is less compliant compared to the cutting balloon itself. So I think that we can go more 1-to-1 ratio.
I must admit, I still with the scoring balloon, especially the one from Philips, I still undersize, because I also think you have to go to very high pressure. And I think, you know, when I worked in Milano, we learned that those nitinol elements actually stop you from getting bigger, right? Because they hold the balloon. So the balloon can't expand more than that. But if you look at the compliance chart of a scoring balloon, in the first sort of, I don't know if you have a compliance chart.
Yeah.
I mean, if you look at the compliance chart, just look at how much it grows. So look at the 2.5, right? I mean, it grows a lot in the beginning parts. I think you still have to be a little careful. That's all I'm saying is I think when you use Wolverine scoring balloons and the OPN, you have to be careful about going 1-to-1.
Yeah.
At high pressure.
Yeah, let's say that compared to cutting, this maybe can be safer, but always take an eye like on the compliance chart.
Because look, a 2.5 balloon in 18 is 2.75, right? You may say that's not a lot, but if you go 1-to-1, okay? So if I think about that lesion where you ruptured, okay, where the media to media is 2.9, right? And now say I took the 3.0 balloon, I would have had 3.31 at 18 atmospheres.
Yeah.
It might have been enough to rupture still.
Yeah. Let's say that if you don't go super high pressure, maybe you can be a little bit more conservative with the scoring balloon and go 1-to-1. If you go higher pressure, you always have to take an eye on that. Let's see this case, Zima. This is a severely, I would say, calcified lesion on the LAD, but in most, if you look at the angio, it seems that calcium is more adventitial. This is a very fragile patient. He's 84 years old, type 2 diabetes, and the ejection fraction is normal, but he has a lot of comorbidities and he had effort angina. You see what is the angio? We have some disease also of the distal left main, another mild stenosis maybe on the circa, but I think here that the culprit is clear cut and is diffusely calcified LAD.
Right.
Okay. You see here that we have the IVUS run. I don't know if someone wants to comment on the IVUS images.
Let's see, maybe if Andrea or Guillem want to comment, some of the fellows.
Yeah, sure.
Okay. And that's Chris. Chris, you'll comment next. Sorry, I wasn't sure you were there. Let's let Guillem first, and then you can go next.
Okay.
Yeah, it looked like a very circumferential lesion and quite long too.
Yes.
So if we adapt the same strategy than before, maybe root ablation could be a nice strategy for the first run. What do you think, Antonio?
Yeah, I think that here the only problem, I totally agree with you, because the residual lumen is small. You have a long diffusely diseased LAD. I think this is one of the best options that you can have, like with rotablation. I think the only problem and the only doubt in this case was the patient itself. I mean, you can do also protected PCI in this patient, but was fragile, 84. He had like a severe PAD, so a lot of disease also at the level of the femoral artery. So was impossible like to be supported even with Impel or EABP.
Can I just ask a question, Antonio?
Yeah.
Maybe again, just for the fellows, right? I mean, the EF was normal in this patient.
Yeah, but
right, so
yeah, the only thing that Azim, I tell you, even if you look at the last paper that has been published on JAK intervention, comparing rotablator with orbital atherectomy, there's still like 12%, 15% of patients who can have like no reflow plus like impairment of the distal flow. We have
I think so. That's the thing we need to bring out for the fellows, right? That in this case, because it's so diffuse, that the risk of distal embolization is higher. I mean, compared to the cases you showed us before, where they were more focal, this is much more diffuse disease. Number one, it's tighter, so the burr is actually going to interact with calcium for a longer duration in the artery. And so the risk of distal embolization is what Antonio is concerned about, even though the EF is normal. Because when you have patients who are frail or have severe pulmonary hypertension or even moderate AS, and they get distal embolization, those are patients who can really deteriorate very quickly. I saw Alessandro also had his hand up. So Alessandro, you wanted to make a comment?
Yes, Azim, exactly. Thank you. It was what you said. It is a long diffuse disease, and the calcium, as you see in the IVUS, there are a lot of reverberations. So we see that it's not such a deep calcium, and it is probably the rota is not the best choice about it.
And I think rota is good, but I think you have to be concerned about distal embolization. Chris, what would you do here? Before Antonio shows us what he did.
Yeah, when I saw this, my first thought was rota, you know, especially when going towards a little more distal where it becomes a little more tapered. You know, I was wondering how far down, you know, did you do IVUS? Because in that mid portion there around around the third diad there, it seems like it's a little heavily calcified there as well. But I would have went to rota initially on this.
Right. I do think that when you do this kind of case, you should be concerned, right, about what can happen. So when I do this kind of case, I'm already, it's a few times when I do a rota case and I already have drawn up things on my table, right? So I already have drawn up a little bit of epi, okay, adrenaline, that in case the patient's blood pressure starts dropping, has no reflow, and I already get like the nipride ready. Okay, and I'm telling the nurses, you know, in the US, Antonio, we use a lot of phenylephrine in the procedure. So I will already tell the nurses to have some neo ready. If I see a drop in blood pressure, I'm going to give some neo. If I get no reflow, I'm going to be ready to give nipride and epi to treat the no reflow. And the other thing I do in a case like this is I do very short runs. All right. One of the things when I see fellows and I'm teaching them to burr, they're all looking at the screen at like the burr intensely. And none of them are looking at the blood pressure and the EKG, right? So you got to like spend a lot of time also looking at the Mac lab and looking at your EKG and your blood pressure. If you see your blood pressure starting to drop, your EKG going up, you have to stop. Let the patient breathe, come back with a burr, let there be flow, give them a little bit of time to recover from the little bit of embolization you gave them, and then start again.
Yeah.
Patricia, any other tricks you have in these kind of cases? Any tips and tricks when you have such diffuse disease and you're going to do rotablation?
Well, it is a diffuse disease, but there is a subocclusion at the beginning, at the ostium of the LED. So probably if you are able to open up the subocclusion, the vessel will appear a bit more treatable than this one, than now.
Okay.
Okay.
And Azim, I think another good sign is that we were able to do the baseline IBUS.
Exactly.
Which is
Yeah, it's true.
because when you
I'm
are
surprised the catheter passed.
Yeah, and this is an IBUS from Boston, which is a little bit bulky.
Yeah.
So, I mean, it's always a good sign. And so I think you have a fragile patient, the IBUS process, you see that there is calcium, it's quite superficial. I think it's a very diffuse disease, but in these cases, maybe you can take the chance to use the non-compliant balloon like we did, the 3.0, and then the scoring balloon inflated at high pressure, especially in the proximal part. And you see that finally the vessel appearance is not that bad. You see some cracks in the calcium. See that doing an injection with the with the balloon inside of the vessel, you see a good flow. There's some dissection in the mid portion of the vessel. But even if you inject with the balloon inside, you see that the distal flow is fine. So it means that you have achieved a good result in terms of minimal lumen area. And I think that if you are dealing with these, complex patients, you can go on like doing your simple PCI, inflating balloon, inflating the stent. We did in this case also kissing balloon on the circ. We did also an IBUS run on the circuit. You see that there was a small tiny dissection, but essentially the calcium was nicely prepared and also the residual lumen on the circuit was fine. And so in these cases, you can go for a provisional stenting. There's nothing bad like to be done.
Looks great.
And you see that finally it looks great. And it's what we achieved simply going with the scoring balloon. So the take-home message in this case is that you have to give a look also to the patient, and with these alternative, balloons, you can obtain a good satisfactory result.
Yeah, that's a great result, I have to admit.
Even if you are pessimistic at the beginning. I think we are running a bit over time.
Let's do maybe one last case, maybe because the OPN balloon has just become available in the US in the last 6 months. So it'd be nice for you to share your experience with everybody.
Yeah, just to say that just briefly, when you compare scoring balloon versus OPN balloon in severely calcified lesion, I think you achieve a better performance using the OPN balloon compared to the scoring balloon. So usually I think it's a little bit out of the topic, but you can use especially the OPN balloon for the treatment of underexpanded stent. If you see here in the proximal RCA that there is a stent inside of another stent, a little nicely underexpanded, I would say. And if you go with the OPN balloon at high pressure, you can have the chance like to nicely expand the stent and to obtain a good result, like changing the area. Let's see this case, severely calcified lesion. I think this case was done by Antonio Colombo. So we are dealing with the boss. Tight lesion treated with the rotablator. The bar crossed nicely. You see that the vessel is severely calcified, especially in this portion. The pre-dilation was performed like standard routine with a non-compliant balloon, and you see that in this case again the non-compliant balloon appearance is not so nice. So here I think that the LAD is diffusely diseased. In case of utilizing like a cutting balloon, I would have used maybe a 2.5 cutting balloon at high pressure. But maybe like you can use in this case an OPN balloon 2.5 or maybe 3 with the risk of having like you take a little bit of chance of having problems. You see at the IBUS, so what is the finding that we had? I don't know if someone wants to comment about these findings after rotablation. Azim?
I said, how about Chris or Andrea? Anybody want to comment?
Okay.
So, yeah, so I mean, we can see there's definitely circumferential calcium. There's a little bit of cracking there, especially at the 10 o'clock region that you see that right there. And then in picture A, yeah, quite. I mean, I mean, that's just stent there, so I don't really see it as much heavily calcified. But I think like this lesion, especially in picture B, needs to be a little more prepared because that calcium, I don't think is.
So what would you do, Chris? What would you do now? They've already done a 175 burr.
Yeah, so at this point, I would either go with probably a cutting balloon or either shockwave to see if I can kind of break it up and then go back in with like a non-compliant to fully expand it.
Okay, so shockwave.
I've only I've only used OPNs like twice. So not a lot of experience with that, but I will probably go back in with shockwave, see if I can break it up there.
Andrea?
Yes, I fully agree with Chris. I think we see all this calcium, we see the cracks, but still we need to do more, probably with the cutting balloon. I will try with the cutting balloon, or if possible, shockwave.
Yeah, in case of cutting balloon, Andrea, in case of a cutting balloon, which diameter?
That's the scary part about using a cutting balloon, yeah, right? Is the diameter you would have to. I mean, you couldn't put a 3.0 in here. In this area where it's 1.71, I'd be a little scared about like a 3.0 cutting balloon, but I'd be less scared about a 3.0 shockwave, for example. I see there was a hand up from Christina Rodriguez. Did you want to make a comment, Christina? Is that why your hand's up? You'd have to unmute if you want to make a comment. Maybe no. Okay. Antonio, why don't you show?
Antonio, why not a bigger bar?
A bigger burr. I think that you see that the residual lumen area is not a dye.
Because we were discussing yesterday a paper on JAK intervention with Prof. Colombo. We were discussing about that in this paper, the orbital atherectomy and the rotational atherectomy gave the same, almost the same result, but they used for the 30% a 2.0 bar. That is something that we don't use currently.
Yeah, I agree with you, but in this case, I think that rotablator did his job because you see some reverberation behind the calcium, and I think that the contact between the burr and the vessel wall already happened because we are dealing like with a tight lesion, and you see that in some areas, you see that the diameters are around 1.7. So 1.75 burr, I think it's more than useful. We were able to cross the lesion. I think that in these cases, maybe the only thing to do is not to move up and down the burr, but just to be and to focalize the burr around the tight lesion. But I think that you can change the technique, but essentially I will not have been like
okay. Let's see what you did, Antonio.
The guiding catheter, etc. I think that it's safer to go with balloon, not safer, but let's say my choice would have been like to go with the lithotripsy. In this case, the predilation was performed with the OPN balloon. You see still some dog boning effect of 20 atmospheres, and you see that the rationale of the OPN balloon is to go very high pressure, 36 atmospheres, and just at 36 atmospheres we obtained an acceptable, let's say, expansion of the balloon, because still some dog boning effect is visible at the floor. Let's see What happened essentially, we obtained, compared to before, a more evident and pronounced calcium fracture at the level of the concentric calcification. And while before the OPN, we observed just one crack. Here we have in the figure B, in the panel B, 2 fractures. There's another part of the vessel you see here from 10 to 5 p.m. To 5 o'clock, essentially that the calcium is still solid, is still not prepared, but sometimes you have like also to choose to be a bit conservative. If you cannot go with the lithotripsy, I think that in this case, my suggestion would be just to not put a stent in this kind of lesion, just do DCB because of the risk of stent, under expansion, not perfect, let's say, performance of the stent itself.
It's a very impressive picture, the one on top, because when you look at how small that vessel was, that's very impressive. So maybe, Antonio, just a last question before we let you go. When are you using OPNs in your practice?
Okay, I use OPN, especially if I have to go, so the crossability of OPN is not excellent. It's difficult to cross a very tight lesion with the OPN as a first intention. Usually I use OPN if I have to deal with not very long disease, quite, located, quite nicely located in the proximal segment of the vessel. I tend to downsize and I go very high pressure, especially if I see that the non-compliant balloon does not expand just in a focal portion, instead that a diffuse under expansion of the balloon. I think this is a very good indication for the use of the OPN. Another thing that I want to remind is that if you go very high pressure with the OPN balloon, usually you lose the wire when you retrieve the balloon, because you have like you create a combo between the balloon.
It clamps on the wire?
Yeah, it clamps on the wire.
And what wire do you routinely use?
Usually, routinely, if I have to deal with complex lesion, I go for a Sion blue.
So I think this is a Sion blue problem. I don't think it happens with other wires. I think a lot of us have had this happen recently. And so when you go with a Sion blue, even with a non-compliant balloon, to very high pressure, it can get stuck. And I think it's a Sion blue defect. I mean, I've noticed it because I've started using more Sion blues. It doesn't happen with universal. It doesn't happen with run through. A lot of my team who do complex PCI, they love run through, and they say it doesn't happen with that, but it's happening quite a lot with Sion blue. So those of you who use Sion blue, just be aware of that. That can be like a real problem, especially if the vessel is dissected, and then you lose the vessel because the balloon's clamped down on the wire. So you end up, when you pull the balloon back, pulling the wire out. There's no other way. So
usually I put like a parallel wire just to safety reason if you have like a big dissection. But usually what I observe, Asim, with the OPN is that you nicely prepare the vessel, but you have not advanced dissection after lesion preparation with the OPN. So if you want to go with like also DCB strategy, maybe it can be very useful. Another application I think is very useful is for stent under expansion. If you don't have a lot of like calcium behind, but your stent under expansion is just done by an incorrect sizing that has been performed before, I think that OPN has the possibility to fight against like the tissue that is behind and usually obtain a good expansion of the previous stent.
Yeah, I think we just need to use more OPNs here. And so learn and build up a little bit more of our own experience on it. But someone was asking in the chat, Dr. Farrow was asking, what about IVL in this case? I think IVL was also a good possibility in this case. I probably also would have taken a 3.0 IVL and tried it. I think it may have given you the same result, but only going to 4 atmospheres, not having to go to higher pressure. Antonio, any final comments before we let you go?
I miss you. That's my final comment.
Now, this is like really awesome. Thank you for the cases. I think all the fellows enjoyed it. I certainly enjoyed it, and I learned from you. So thank you for teaching us. I'm going to ask you for some of your slides, because there were some great slides on mechanism of action, because that's one of the things, maybe as like my final message to the fellows, is that we have all these tools, and to understand using these tools properly, okay, and to use these tools properly and get good results, you have to know the tools. So you have to know how they work, what's their mechanism of action, the compliance charts, and that's how you use them safely and you use them appropriately. So please, please, please don't, just say, oh, I want this balloon. Spend some time after the case or before a case. If you think you're going to be using shockwave, if you think you're going to be using cutting, look at the compliance chart, understand what happens with the balloon at different compliances, compare different balloons, hold them together and compare the compliance chart. Just get to understand your devices better. It will make you a better operator. There was one question here, is what do you recommend as the minimal setup of balloons in countries or areas where there are lots of cost constraints? So I would say, and let's see what you say, Antonio, you need to have non-compliant balloons. I don't use semi-compliant balloons anymore. I only pre-dilate with non-compliant balloons. If I had to choose between Wolverine and a scoring, I would choose Wolverine. If I had to choose one, and I think you need at least those two. IVL is becoming, I think, an important part of what we do, especially if you're in centers where you don't have a lot of rotor experience. It can sometimes get you out of trouble. I would keep an IVL balloon and reserve it for special cases, especially if there were cost constraints. But the other important thing that I want to mention, that Antonio showed you in every case, he did imaging in every single case, right? And if you're going to be successful in treating these complex lesions, you have to use intracoronary imaging. It's what makes us better. It what allows us to choose the right device and choose the right size of the device as well. So, Antonio, would you add anything?
I think I agree with you for the selection of the balloons. Just to start an activity, I think cutting balloon is maybe superior to scoring balloon, maybe equivalent to OPM balloon, but it's more, flexible. And remember that cutting balloon is always good also for treating instant restenosis. So it has these two, let's say, advantages. For lithotripsy, I think lithotripsy is safe. Most of the interventional cardiology wants to have safety first, but we do a lot of IVL without, understanding why we are using IVL. I think if you see calcium does not mean IVL, like is becoming the standard for a lot of people. I think we have to reason about things. Doing intravascular imaging can give us the possibility to better understand what we are doing, and don't be lazy when you do cases. So pre-dilate, repeat imaging, do another step if you want to achieve the best thing for the patient, and try to understand always what you do.
Antonio, thank you so much. All the fellows, thank you for joining in your discussion. Grazie mille. Ci vediamo settimana prossima a Milano.
Grande. Ciao.